today's session is about organizing palliative care services. Let me first introduce about the state facilitation team. So this is a division which takes the Palliative's work across the country with a vision to facilitate and access palliative care to all those who are in need. So details we'll be discussing in the later slides. So what will this session give you? The session will brief you exactly about how you can open a palliative care center in your region. You may be already part of some hospitals or individually maybe you're already doing it. But for those who haven't yet started, so we shall guide you on how to start a palliative care center in your settings. We'll start with this. So this is a WHO palliative advocacy triangle. We call it advocacy triangle. So as per the WHO, to set up a successful palliative care center or to organize palliative care service, we need to ensure these three things. Okay, so as you can see, it is the education in one corner and drug availability in the other and the policy. So coming to the education, there are barriers to palliative care, we all know, which will have to be overcome through education. So we all know that there is a lack of awareness among the professionals, lack of awareness among administrators, lack of awareness among the public. So it is essential to educate the public. So public demand does persuade professionals and administrators to think. So that's why education is very important and awareness is important. Now moving on to the next corner, which is drug availability. So pain relief, as we all know, is an integral part of palliative care, and for that, availability and accessibility of pain relief drugs is very, very essential. For example, morphine is a mainstay of pain management. Its availability has been eased to some extent, to a small extent, by amendment of the NDPS Act. But most states, because we work in different parts of the country, we have regional facilitators, so we discuss and we talk to the government officials. We know that many of the states are yet to implement. So here we are emphasizing on the drug availability, which is one corner of this triangle. Now coming to the policy and its implementation. So in much of the world, palliative care came into being because of individual initiatives and action by some non-government organizations. However, to achieve national coverage, palliative care needs to be integrated into general health care delivery system. So that's what exactly Pallium India is working for. So we want to integrate it and not keep it as an independent. So government action is also needed to remove barriers to access to pain relievers. It is essential for budding services to develop their own policies that can overcome any gap in available facilities. So when we plan for a palliative care, since here we're discussing about how to open a palliative care service. So when we plan this, we have to remember that you should be trained. You should have the opioids available to you, and also there should be a policy or a program available to support your service. So coming to the Indian context, we can see that we have three major categories. One is the standalone, which is a standalone hospice or a palliative care center. The second is a department. Maybe a unit within hospital. It can be a government hospital, a charitable hospital, or for-profit or sustainable. And the third one, as you can see, is a community-based home care. So let us now discuss a little bit in detail. So what is a standalone? A standalone model is an independent facility where we provide palliative care with specific focus on pain and symptom management and improving quality of life for patients and their families as well. So this can be done through a hospice or a palliative care center. So in the next slides, we will see some photographs of standalone. Moving on to the next one. The next one is a department, or within a particular hospital, you have a palliative care, dedicated palliative care center or a room or OPD. So this is, you have a dedicated room, which can be a government hospital or a charitable or profit-making hospital. Coming to the community-based home care, here it is a bit different. Here where the community gets involved. When we are talking about community, obviously the community comes into the picture. So here we reach to the care receiver where they are. So the team goes to the particular community Here, the social capital act as a bridge between the micro and macro, and the major element of the social capital is the volunteers. Yeah. So here, as you can see, some examples of the standalone hospital. We have Sipla, we have the Guru Ramdas Hospice, and few more. So this is again in Calicut, we have this one, and in Karunashra, this is in Bangalore. So these are all standalone. So now the next one, as we were discussing, within a hospital. So this is a particular hospital in which they have a dedicated room. So these are the palliative care services being provided through this particular dedicated rooms. Okay. Now we are talking about the community model. We want to discuss what is a micro, meso, and a micro. As you can see, it's showing that we have a micro and macro. So when it's come to micro, you can see there's only a one individual, and micro is a big hospital where actually the patients try to reach. But here you can see there's a meso, so which I was talking about, that the community, where the community is, the team is reaching them. Okay. So this is actually the Kerala palliative care model. What we do is we bridge the gap between the macro and the meso, and the team reaches out to the community and where the patient is. Okay. Okay. Now this is a very interesting story about one of our volunteers. So as you can see, his name is written. His name is Mr. K.N. Nair. So he is a very dedicated person, and he has been associated with Pelham India since uh, his wife was actually like she was not well. So we call him fondly, we call him Nair uncle. He is 70-year-old and he's an ex-serviceman. So he got introduced to Parliament as a caregiver for his wife who was under our care. He serves as a volunteer after his wife passed away. He goes with one of our home care teams and is involved in patient care more than our clinical team. So he's also known to our beneficiaries more than our team. He's so like attached to the beneficiaries. He always has a small notepad in which he keeps all data of the patient, and he keeps in touch with them over the phone almost regularly every day. Our beneficiaries are more comfortable to talk to him, call him, and share their issues. So he's never ordered, like as a volunteer, he is supposed to like do whatever is convenient for him, and there's no time limit. So he really is a very dedicated person. He feels as if he's doing these follow-ups in his own responsibility. So this is an example of our volunteer, Naira. Okay, now moving on. This is, as you can see the slide, it's a 10-step approach. So this is the crux actually. So these are the process we need to follow to start a particular palliative care services. So the first one, as you can see, is arranging funds. But obvious. So for starting anything, we definitely need some funds. So if you are a part of government hospital, there are funds available through various programs like NPPC or Ayushman Bharat. For private, of course, you can create a service and you can charge for it. If it's for charitable or individual, where the actual challenge is, for them, we can go to the CSR or public donations. So you should have an idea which source you will be opting for. This is for the arrangement of funds which I'm talking about. So once the funds are arranged, we can think of recruitment of or training of a team. So this is also an important aspect of setting up a palliative care service. Initially, you'll have a doctor, a nurse, and a social officer. So what we call as the basic model, in a particular basic model, these three are the required. These three people are the basic requirement: a trained doctor, a trained nurse, and a trained social worker. So going forward, as you grow, you may require allied medical professionals like pharmacists or physiotherapists, occupational therapists, dietitians. I mean, this depends on what kind of other services, extra services you're going to provide. So accordingly, you can hire. So as a basic unit, as I said, we would need a doctor, a nurse, and a social officer who should be trained in a particular palliative care training. They should have the basics of palliative care training. Now, coming to the next one is you should definitely have an infrastructure. So it can be a room for the OP, or a space and a furniture for the inpatient unit, or in case of home care. Suppose you plan to start with home care, then definitely you need a vehicle which can be used by a team to travel to the needy with all essentials like medicine and other consumables. So I just want to repeat this. So when we are talking of only the OPD services, so just a room is enough. Just it can be a room, a particular space within a hospital. You can start with. For inpatient, definitely you need at least 5 bedded, or depending on what infrastructure you have. And then coming to home care, as I said, obviously home care will need a little more of investment. So we're done with arranging of funds, recruitment, and then building of infrastructure. Then this leads to, now we need to procure opioids. So as I mentioned in the starting, we need to ensure availability of essential narcotic drugs for pain relief. Obviously, when we're dealing with palliative care patients, we'll need this. So to procure, store, and dispense opioids, you need to be part of a recognized medical institution. Actually, in short, it is called RMI, which is a 3G certificate. 3G certificate, which we need to procure. And here I would like to mention that all the government hospitals are, deemed RMIs. They don't need to apply for any certificate. But other than the government, any private hospital or NGOs dealing with palliative care and want to procure opioids, they have to apply for this. So for getting this RMI, we can also help. Like we will can share the forms required, how to apply. So we can help out with this. So it's a lot of information required for understanding this topic. So you will have a different actually session on it. So at that time you can get all your doubts clarified. Now coming to the next point, after the procurement of opioids, now you have network building and established connects. So you need to establish connects with existing experts in palliative care in your region, but obvious because you need their help. So this will help you to understand the local challenges and support available. So that's why this networking is important. Now after that, you need to arrange awareness sessions for the public as well as your team to help them know about palliative care, a little bit more about the palliative care. This will help you to get referrals as well as identify local champions who can take your work to more people. So that is why here we have mentioned create awareness specially because this is very important. Unless the need is created, people may not come to your setup. Now coming to develop OP. So developing an OP, maybe you can have a local hall, as I was mentioning earlier, a classroom of a school, colleges, depending on which region you are and how, where you're placed and how big you want to set it up. So just ensure that all facilities that you find are disable friendly. This is, I just want to highlight this. You can just have an examination table, a chair, or some basic furniture and essential medical equipments for conducting an outpatient unit. So this is for the developing of the OP. Now coming to developing the IP. For developing inpatient facility, it will involve little more infrastructure in terms of beds or side lockers, etc. I mean, I think you know better than me. So now coming to developing home care services. This is very interesting. You can start with one vehicle which can accommodate the team of doctor, nurse, and a social officer, and medicine and consumables. So there are scenarios where just a doctor or nurse go on a two-wheeler for home care also. So here I would like to just share my experience. In my last visit to one of the organization in Orissa, they have started palliative care, home-based palliative care. So they're using the local Ola Uber facility, and they're reaching the patient. So there are different innovative ways, and it depends on how passionate you are about to give the services. Now, the last, as you can see in this slide, the last block shows involved volunteers. So we all understand why volunteerism is important. So as mentioned earlier, just a basic flow that we follow. It's not a concrete rule. So whenever you want to start something new, you can refer this, but this is nothing like you have to follow this particular exactly. So you can have your own plans. Now I've moved on to the next slide. So here you can see it says strategy, and there's a one triangle in the middle which shows government, for-profit, charitable, and sustainable subsidized. Sorry. So now we'll look into how we support, facilitate palliative care service with already discussed models. So here to the left corner, you can see capacity building. So capacity building is one of the major support that we are providing. Workshops, orientations, foundation course for doctors, that like the one you are attending now. Then for nurses, health workers, training of faculties. So there are various capacity building, uh, you know, programs we have. Okay. Now for opioid availability, the next one is availability of opioid. For opioid availability, we support in getting the NDPS Act implemented. We create awareness for medical institute about the new RMI process, and with the state drugs controller, we try working with NHM, the National Health Mission, to get the opioid included in state essential drug list. So basically, we are trying to make it easy, stepwise, to understand the particular system. So we do also handholding for the PCU at district level, connecting local palliative care networks. We provide documentation assistance and support. So also we help them in developing program implementation plan. For each state we have a PIP, so we help them in doing that. Implementation of NPPC, development of palliative care through health and wellness centers. These are all the government schemes I'm talking about, Ayushman Bharat scheme. So Palliative contributes towards developing a state palliative care policy. We do have regular connects with the Ministry of Health and Family Welfare for developing peace palliative care in states. So these are certain ways that we work. So we help recruitment also. We help recruiting human resources for starting a palliative care center. We facilitate cost management and sustainability. We help build funds through donations and help in grants and CSR application. We have new process called implementation team support. This is very interesting. So suppose any one of you is planning to set up a particular center in your region and you want a handholding support. So once the team is ready, so we'll send an implementation team to a region. Our team of, it can be a doctor, nurse, and a coordinator to your site. So they'll stay there with you, handhold, and it can range from about 1 week to 10 days to even 1 month if required. So of course, this will be a paid service like that we can discuss later. So this is something we are coming up with and looking at the demand all across the country. Okay. So now we have talked about how it should be done, what are the facilities, how we can go about it, what are the steps. Now let's discuss a little bit about the challenges. So it's very clear in this particular slide. So we have just separated the government limitations, like government challenges. So let me just pick up the government one first. As you know, we have limited budget for palliative care. Then medical colleges that are dependent on state budgets, so no provision. Then palliative care is not a priority among all programs. As you can see, there's a communication gap. There's a reluctance in collaborating with NGO. The trust issue is there. Then getting an appointment is always a issue. Then we have to do endless follow-ups. These are the things. Now, general challenges are like you have, you know, uh, for the palliative care setup, people want to just play safe, and that's the reason many of the states they do not want to go for this license. This I'm telling about with my experience, because when we talked to them, they said no, we are happy with the old license. So it's all about they don't want to take the risk, and of course, inadequate knowledge is one of the reasons. Then they do not have trained human resources. And the most important, as you can see, we have highlighted it, they do not consider it as very lucrative business. It's not a money-making business. That's the reason it is uh, not taken, people don't take much of interest in this. Okay. So moving on from the challenges, and I think this is not the only challenges. There might be many more, but we have not jotted it down. So we just put down the basic ones. Okay. So now, as you can see, this is a standard audit tool for any palliative care program. We suggest that it should have a this kind of audit tool. So basically, it is a kind of self-evaluation audit tool for palliative care centers to know where we are standing. So there are two parts. Part A, as you can see, is essential, and part B is desirable. So obviously, essential means that it should be there, and the ones listed in the desirable are regular requirements, as you can see. So we can just skip this for now. Okay. Coming to the next one, let me explain a little bit about the Palliative model, how we work here. So we in Palliative follow a model called DEF. So D stands for demonstrate, E stands for educate, and F stands for facilitate. So facilitate is the group, the team where I work. Okay. So let me go one by one. So for the demonstration, let's discuss. So the demonstration model is a proof of model that we take to our stakeholders so that potential stakeholders like you all can learn how to deliver palliative care. So here we have TIPS in Trivandrum. This is Trivandrum Institute of Palliative Sciences. Many of you must be knowing it, which is also a WHO collaborating center for training and policy for access to pain relief. So for the D, this is how whatever we do is demonstrated there in tips. So this is the Palliative's office, Trivandrum Institute of Palliative Science. We call it tips. Okay. So we have inpatient care, outpatient, home care. So these are the facilities we have there. We also do rehabilitation, community participation. We have link centers. We have halfway home. So quickly now I want to just give you a information about our palliative care helpline. Okay, so here you can see that there's a helpline mentioned, and here I want to also inform. I'm sure many of you must have tried this. So what happens is that many people call, and then there is a they expect that somebody at the other end will respond, but that doesn't happen work that way. You have to say your message after the IVR. I mean, sorry, the beep. So after your message is recorded, so the team will get back to you. So just I wanted to explain and tell everybody because so that don't get disheartened that this number is not okay. So quickly resuming the previous thing. So we were talking about the demonstrate model. So now is we're talking about the education. So in education model, I discussed earlier that we do the lots of kinds of trainings, which includes for doctors, for nurses, volunteers. Here I want to mention we have a beautiful program which is free of cost for volunteers. Since we are emphasizing more on volunteers, so we have volunteers training happening in Pelham, India also, which is also online. It's a 5 days training program. So anybody can attend it, and we also get a give you a certificate after the end of the training program. See here, we have jotted down some of the courses. For the doctors is FCPM, which is the online one, which you all are attending. Nurses we have for FCPC, we have FCPC's foundation course in palliative care, which is for the uh, all allied healthcare professionals, not necessarily doctors. As I was mentioning, volunteers also are there, student volunteers there. So a lot of trainings, and this is just a list, a lot more. So just to give you an idea about what all we do in education. Okay. Now coming to facilitation, which is the DEF. When I said DEF, so we for F we have facilitation. So here I would like to emphasize and explain that we have 4 regional coordinators, facilitators in different regions. In north, we have Rajendra, who is based in Uttarakhand, and he looks after all the northern region states. So in the northeast, we have Rontu Sangma. He's based in Guwahati and he looks after the northeast parts, all the states, specifically the Seven Sisters, and also he looks after the West Bengal. Okay. So in central region, I'm taking care. In the south, we have Mr. Lalit, who takes care of all the south region. And now we have a new person, Mr. Askari. He's joined recently, so he'll be also managing some of the states. So I think all our contact details will be shared to all of you. So you can pick up and contact us as per your regions. Okay. So this are in the map we have shown which are all the states we are taking care. So first one is the north, and this is the northeast states that we're taking care. Then this is central zone and south. Okay. Now, just quickly, we are moving on to little bit more about the facilitation. So, what is the philosophy of this particular team, state facilitation? We actually aim to integrate at all three levels, the primary, secondary, and tertiary. So, basically, we have the following five objectives. First is the catalyzing palliative care centers and services. As mentioned in the beginning, that we help in end-to-end facilitation. For example, if any one of you contact us that yes, I want to start. So from there, our handholding will begin. Like we will share you the guideline, and then we'll understand what exactly you have, like where you already have some infrastructure or you have trained people. So then we'll start from there. So it is end-to-end facilitation for catalyzing centers across various categories. It can be in government also, in charitable or for profit making also. Okay. So this is the first one. Second is we assist in opioid accessibility by facilitating in getting the RMI. I was talking about the RMI certificate. So this is a long procedure that involves which you will learn through opioid availability session later on. So we help our stakeholders to go through each documentation like filling out applications, talking to the drug controller, maintaining records, etc. So here I want to say, just explain how our team works. So as a regional facilitator, in every state, there are two major government departments that we touch upon. One is the National Health Mission and second is the State Drugs Controller. In some states, it's called the FDA, Food and Drugs Authority. Like in Maharashtra, it is called FDA. So we reach them, we find out what's the status, have they been issuing RMI, so then it becomes easier. Suppose somebody in Maharashtra contacts and we know that it is already being issued. So the process becomes easier. If it's not started, then we need to talk to the drugs controller, convince them, take some sessions with them. Then it takes a little bit of time, but later on it is done smoothly. Oh, so this is our role in uh, facilitating how you can get the particular license. Now, we enable palliative care learning in medical institutes. So what we do, as we all know that education plays a major role in delivering palliative care. We try to work with medical institutes to involve palliative care in their undergraduate curriculum for doctors. Here we work with the trainers. So then they train the students in palliative care. This is also a beautiful system in place that we do. So this also helps in a lot of awareness among the medical students. Then we work with stakeholders to help them build community engagement and help them mobilize volunteers. As you all know, Kerala model is mostly volunteer based. So here in Palliative, we create a lot of awareness among the public, get similar interest people together. Then they form a group as a link center and they take ownership of palliative care across their region. So it is not, it is actually from the volunteers to the service setup. So they demand that, we have palliative care patients in our region and we want your services. So it's like that. Then we do have pain-free hospitals. So this objective is a budding state right now. We do not have much, but then The concept is where any patient that enters for any treatment is assessed or treated by the pain score, and the pain score is measured by a scale which ranges from 1 to 10. Okay? So this is the basically the philosophy of our team that we work for. Here is the national president, that what all we have done in different states. We have reached so and so many state governments, and we've done catalyzed so many centers. On-site foundation. On-site is the team is either they invite us to their region or they come to Parliament. Yeah. Then we have faculty development programs and hands-on training, opioids. So we have lot many activities happening, as you can see in the map. So different activities happen. It's not you know it's not uniform all across the country. Different things happen, but mostly most states are covered. Yeah. Thank you.